Welcome to our YouTube channel, Medicine Study Companion. In this video, we will recap on oculomotor or third cranial nerve palsy. We will discuss about the anatomy and clinical manifestations of third cranial nerve palsy. Anatomy. This diagram illustrates the pathway of the oculomotor nerve, and according to that, the oculomotor nucleus is located in the midbrain and it has several supplies. It supplies the levator muscles of the eyelid, the levator palpebrae superioris, and 4 extraocular muscles. What are the 4 extraocular muscles supplied by the oculomotor nerve? As you can see by the red tracings in this image, the oculomotor nerve supplies the superior rectus, medial rectus, inferior rectus, and inferior oblique extraocular muscles. And also, oculomotor nerve causes pupillary construction through parasympathetic fibers that supply the smooth muscle of the ciliary body and the sphincter of the iris. Therefore, during pupillary light reflex also, the pupillary constriction is caused by the supply of the oculomotor nerve. Regarding this nerve supply, the supply for the levator muscles and 4 extraocular muscles, we sometimes call it the external supply, and the autonomic or parasympathetic supply for pupillary constriction is called the internal supply. That is the basic neuroanatomy of oculomotor nerve. Then, let's look at the clinical manifestations of oculomotor nerve palsy. We can divide clinical manifestations into 3 categories: complete external dysfunction, complete internal dysfunction, and partial internal dysfunction. Here, the external dysfunction means there is impairment of nerve supply for the extraocular muscles which supplied by the oculomotor nerve and the levator muscle. The internal dysfunction means there is impairment of parasympathetic supply. In complete external dysfunction, there can be complete ptosis due to paralysis of the levator muscle, and due to paralysis of the extraocular muscles, there is paralysis of adduction, elevation, and depression. As you can see in this image, the elevation is done by inferior oblique and superior rectus with their movement, and both are involved when there is oculomotor nerve palsy. So, elevation is impaired. And the medial rectus causes adduction, and inferior rectus helps in depression. Due to paralysis of medial rectus and inferior rectus, the adduction and depression is impaired. So, in a patient with oculomotor nerve palsy, there's unopposed action of lateral rectus and superior oblique extraocular muscles. Then, in the affected eye, the patient's gaze is towards downwards and outwards, as you can clearly see in this image. Complete internal dysfunction or pupillary sphincter dysfunction. In complete internal dysfunction, the pupillary constriction is completely impaired. Therefore, there will be dilated, large, unreactive pupil. As you can see in this image, the pupil will look large and it is unreactive. In partial internal dysfunction, the parasympathetic action is partially impaired. Therefore, there is anisocoria or else unequal pupil sizes. If you check the pupillary sizes of the patient, it will look like it is seen in this image. And also in partial internal dysfunction, there is sluggish but reactive pupil. Like that, the clinical manifestations of third cranial nerve palsy can be detected in a patient. So, there are complete external dysfunction features, complete internal dysfunction and partial internal dysfunction features. Sometimes these clinical manifestations is just categorized as complete palsy or partial palsy. The complete third nerve palsy means both external dysfunction and internal dysfunction, and partial oculomotor nerve palsy, usually the internal dysfunction. So in this video, we discussed about oculomotor nerve palsy, mainly the anatomy and clinical manifestations. In anatomy, we discussed that oculomotor nucleus is located in the midbrain and it has several supplies, including the levator palpebris superioris muscle, 4 extraocular muscles, and parasympathetic supply for pupillary constriction. And the clinical manifestations of oculomotor nerve palsy can be categorized into 3 categories: complete external dysfunction, which causes complete ptosis and paralysis of adduction, elevation and depression; complete internal dysfunction causing large unreactive pupil; partial internal dysfunction causing anisocoria or unequal pupil sizes; and sluggish but reactive pupil. So these are the clinical manifestations of third cranial nerve palsy.